Hello, everyone, and welcome to the webinar for the Bariatric Surgery Special Interest Group of the Academy for Eating Disorders. Our webinar today is entitled Alcohol and Drug Abuse After Bariatric Surgery with Dr. James Mitchell. My name is Robin Cisco, and Colleen Schreier and I are co-chairs of the SIG and will be serving as your moderators today. Also with us are Courtney Island, AED's Marketing and Communications staff member, and Dawn Gannon, AED's Deputy Executive Director. So just a few items for housekeeping before we get started. All of the participants are muted with the exception of Dr. Mitchell and the moderators. The webinar itself is scheduled for 55 minutes and is being recorded. We will post it on the SIG website shortly after we finish for members of the SIG to download at their convenience 24 hours a day, 7 days a week. Instructions for how to access the recorded webinar will be distributed through the community. In just a minute, Dr. Mitchell will begin his presentation, after which he will answer questions from the audience. You can feel free to submit your questions during the presentation using the Q&A feature on the Zoom box on your screen, which hopefully you can see. And Colleen and I will read them when the question portion of the webinar begins. Dr. Mitchell, can we check your volume quickly? If you say a few words and if a couple of the participants can let us know if they can hear him, that would be great.
Sure. How does that sound?
So it looks like we've got a few responses that people can hear you, so that's great. Thank you everyone for letting us know that the volume is good. So I just want to begin by introducing our speaker. I'm sure many of our members are well acquainted with Dr. Mitchell's work and know how difficult it was to introduce him in just a few sentences. But for those of you who are not familiar, Dr. Mitchell is a board-certified psychiatrist, a former president and founding member of the Academy of Eating Disorders, and the Chester Fritz Distinguished University Professor Emeritus of the University of North Dakota School of Medicine and Health Sciences. Although his grant support and research interests have really spanned a very wide range of topics on eating and weight disorders, most pertinent to our topic today, Dr. Mitchell has served as the principal investigator of the studies examining psychosocial issues and NIDDK's longitudinal assessment of bariatric surgery studies. And recently, he has really pioneered work to better characterize alcohol and drug use following bariatric surgery, which is of significant clinical interest to providers working in this area and is exerting an important influence on the evolution of the field. And I certainly know it's something that I often refer to with my own patients clinically. So without further ado, Dr. Mitchell, the audience is yours. Thank you so much.
Well, thank you very much for introducing me. So this is a topic that has generated a lot of interest in recent years. It's become quite clear, I think, that there are problems with both alcohol and drug abuse after bariatric surgery. Although there's still a lot of open questions, and we'll try to highlight some of those. I think the data are very convincing at this point. So I'll start with the next slide, please. I wanted to thank Robin and Colleen for doing this, organizing the SIG, and also for being co-chairs of the bariatric SIG. This is an important area, and I appreciate their dedication to this task. Also wanted to thank Kristen Von Ranson, who is the AED Webinar Committee Chair, and Dawn Gannon from the Academy for Eating Disorders. Next slide, please. So there are two large multi-center studies that have been done looking at alcohol abuse, and I have abuse, dependence, misuse because of the fact that this terminology changed from DSM-4 to DSM-5 after bariatric surgery in adults. One of them is the longitudinal assessment of bariatric surgery 2, which I was involved with, and this was a prospective longitudinal, at least 7-year minimum follow-up study of a fairly substantial cohort of people on bariatric surgery. Patients completed self-report audits and also self-report on a number of other drugs of abuse, including marijuana, which seems to be sort of a new target right now. There were a little over 2,000 patients, about 80% were women. The baseline median age was about 47, and the baseline median BMI was about almost 46. So this is a fairly typical group of patients and with undergoing bariatric surgery. These data were collected at 6 sites around the United States. And next slide, please. So this is, I'm going to show the data for Roux-en-Y. And one of the problems with labs was that the sleeve was brand new when labs started many eons ago. And because of that, the sleeves are really underrepresented and underpowered. And because of that, we can make some conclusions about Roux-en-Y gastric bypass, but we really don't have good data on the sleeve in the LABS 2 protocol. So looking at this slide, the blue line is regular alcohol consumption over time, out to 7 years. The red line is alcohol use disorder symptoms, again out to about 7 years. And as you can see, it looks like a little over 16% of patients develop alcohol use disorder symptoms. The green line is illicit drug use, and that also goes up. And the black line is substance use disorder treatment, and that goes up as well. So what you see here is, I think, fairly convincing evidence that there is a problem. And given this population and their age, the likelihood that this is by chance is extremely unlikely. Next slide, please. This is looking at the same data using Kaplan-Meier cumulative incidence. In other words, if somebody meets criteria at some time point, they're included in the cohort. So somebody could meet criteria for a period of time and then cycle out of the criteria. Again, the red line is alcohol use disorder symptoms. And as you can see in the cumulative incidence, it goes up to slightly more than 20%. Also, if you scroll down to the green, which is illicit drug use, again, there's clear evidence that drug use is going up. And the drug we're going to focus on a little later in the presentation are the opiates. So next slide, please. So if we look at predictors, what do we find in terms of pre-surgical predictors of problematic alcohol or illicit drug use? The alcohol, nothing surprising here, male sex, younger age, self-reported less social support, being divorced, and smoking cigarettes. Illicit drug use is a little different. Low income also pops up here, and an income of less than $25,000 a year means a number of these people are unemployed. Antidepressant use and having been hospitalized in a psychiatric unit in the last year. So those are the things we can look for trying to identify high-risk patients. Next slide, please. Now, this is an analysis that just came out from Pittsburgh. And what they attempted to do was look at sensitivity and specificity of various cut points to see if cut points could be used to identify people who had developed alcohol-related problems. And frankly, this didn't turn out particularly well. For example, drinking greater than or equal to 2 times a month, that's pretty good sensitivity, not very good specificity. The opposite is true of drinking more than 3 drinks on a drinking day. And then the audit C score of 3 or greater. That's the summary score of the first 3 items on the audit. A little better, but this really did not identify high levels of sensitivity and specificity that we used. It really suggests we need to focus on asking questions and not just of patients, probably also of family members. Next slide, please. Now, the other longitudinal study is from Sweden, the Swedish obese subject study, which actually has been going on now for about 20 years. And these are the data out to 10 years on proportion of patients with self-reported alcohol problems. Now, this requires a little bit of explanation. When this study was initiated, one of the procedures that was commonly done, actually the most common procedure in Sweden, was a procedure called the vertical banded gastroplasty, which is a surgery that's really not done anymore in Sweden or in the United States. Gastric bypass was reasonably well represented, and that's the dark black line. There were some bans, and you can see relative to controls. And basically what this shows is that particularly the gastric bypass goes up fairly dramatically and reaches about 6% at 10 years. A little different figure than the last two studies, but nonetheless still impressive. Next slide. And this again is Kaplan-Meier cumulative incidence. And what you see here is that gastric bypass goes up and then seems to plateau after 10 years, right around 10%. So again, a different figure than we found in labs, but nonetheless fairly good evidence that there's clearly a problem, highly statistically significant problem. Next slide, please. Now, the question then becomes why? Why is this happening? And there's figuring out the mechanisms has been one of the major challenges, and probably is multifactorial. One of the changes that has been well documented now are changes in the absorption of alcohol after bariatric surgery. It appears that alcohol gets dumped into the small intestine much more rapidly, and so it is probably hyperabsorbed in those patients. Now, these are 3 studies looking at Roux-en-Y gastric bypass, and red arrows point to pre-surgery or control data, and blue arrows, excuse me, point to post-surgery data. And what you can see is that the alcohol appears to be absorbed much more rapidly, at least in the Klokov study, and achieving much higher serum levels. And the area curve is quite a bit higher after Roux-en-Y gastric bypass. The Woodard study at the bottom actually had data from 3 months and 6 months. And this suggests that actually the absorption goes up over time. Now, if you look at these data, most of these studies, actually all of these studies, began monitoring levels at 10 or 15 minutes, which is the standard way you do alcohol self-administration studies. The problem is that the first data point is always the highest, and that led us at NRI to develop concern about whether or not we were actually capturing the peak. Next slide. So these are data, Christine Stefan was the first author on this paper. These are the same curves. The one on the left is more compacted and the one on the right is spread out. What we did in the study was actually measure serum levels every minute for the first 5 minutes, and then less frequently after that. And what this shows is that actually the peak for most patients comes way before 10 or 15 minutes. And it's much higher than we can anticipate based on the alcohol load. So these data and the other data that I've shown show that alcohol peaks are very early and much higher than we would anticipate in controls or in pre-surgery patients. Next slide. And that, of course, would be legal intoxication in the United States. Next slide, please.
There you go.
Now, these are data that were just published by Yanina Papino's group. She runs a research group at the University of Illinois, and Anna Champagne has been doing some very, very interesting work. And these are the best data we have on sleep. And as you can see, the pre-surgery line is the sort of, I guess, those are triangles. But then sleeve gastrectomy and Roux-en-Y are both elevated in this data set. And the thing Yanina makes very clear in the write-up is that negative studies in sleeve gastrectomy have mainly used breathalyzers. Now, the problem with breathalyzers is that really can't measure levels before about 10 minutes because of the fact that there's a residual alcohol in the mouth from having ingested the alcohol. So Janina makes it very clear here that you really have to measure serum levels, and you have to start measuring serum levels very early. And these are the best data we have so far on sleep, and it suggests that there's a similar problem in sleep patients that there's also in Roux-en-Y gastric bypass patients. Next slide, please. So summarizing the data so far, Janina's data and also data from NRI, this suggests that in pre-bariatric surgery patients, the serum level usually peaks at about 25 minutes, plus or minus. After Roux-en-Y, it usually peaks at about 5 minutes, and after vertical sleeve gastrectomy, it usually peaks at about 5 minutes. So these data suggest that there are problems with both Roux-en-Y and sleep. Next slide. Another contributing factor probably is diminished secretion of alcohol dehydrogenase. Alcohol dehydrogenase is the enzyme system that breaks down ethanol into acetaldehyde, and that is converted by aldehyde dehydrogenase into acetic acid, which is excreted. Alcohol dehydrogenase is produced primarily in cells that are excised during surgery in a Roux-en-Y. We don't know much about what actually happens in sleeves yet. It appears in Roux-en-Y that a lot of these ADH producing cells are eliminated, and that suggests that there may be an impact on alcohol concentrations here. As far as we can tell, this is not a major player. It probably accounts for less than 10% of alcohol breakdown, but nonetheless, it is a contributing variable. Next slide, please. Perhaps most interesting is these data, which have now been replicated by a couple of different groups, suggesting that it's not just kinetics and it's not just alcohol dehydrogenase, it's also something centrally going on. These are studies looking at IV administration of alcohols in animal models. And what you see there is that 1% alcohol is absorbed preferentially after Roux-en-Y gastric bypass compared to sham animals. Now, this gets rid of the absorption problem. It gets rid of the alcohol dehydrogenase problem. It really suggests that something is changing in the CNS, in the reinforcing properties of alcohol, in addition to the other variables we talked about. Next slide, please. So pharmacokinetic changes, alcohol dehydrogenase reduction, CNS changes, other changes we don't know about yet, that's possible as well. Next slide. Now, again, these are data from Janina's group at Illinois. And what this shows is if we administer sucrose to normals, generally they say it tastes good or really good. And if we administer to them repeatedly, generally they still like it. However, after Roux-en-Y and after sleeve gastrectomy, this changes. And after repeated administration, they don't like the taste anymore. This doesn't happen in lap band, but it happens in both Roux-en-Y and vertical sleeve gastrectomy. And it suggests that the hedonics of sucrose changes to unpleasant very rapidly after bariatric surgery. Next slide. Thank you. Now, we're still trying to figure out exactly what's going on with this. This is data suggesting that it may have something to do with the ghrelin receptor control of ventral tegmental area dopamine firing. This is animal data, but it does suggest that there's a change in VTA firing, which causes release of dopamine into the nucleus accumbens. This may be the mechanism. We need more data. If we figure out this is the mechanism, then there may be some way to address the problem. But there does appear to be, if you will, wiring changes in the way ghrelin affects the VTA. Next slide. Thanks. I also wanted to present some data from the TAB study. This is a study that originally started out as an ancillary study to the adult lab study, but now is funded independently and actually is funded now through 2021. This was a much smaller study, 242 adolescents aged 12 to 19. And we're actually adding 30 additional sleeve patients this year because the sleeve was underrepresented. And these people are evaluated preoperatively at 6 months and then every year thereafter. And because of the nature of the funding, we'll have 10-year follow-up data. The main instrument here is the audit. Next slide, please. So if we look at the age at surgery, as you can see, we had a really nice spread, beginning with 13 to 15-year-olds and going up to 18 to 19-year-olds. It was a nicely distributed sample in terms of sampling adolescents. As many of you know, adolescent patients with severe obesity mature earlier, and so may be candidates for bariatric surgery at a much earlier age. Also, if you look at BMI in the lower right, what you see here again is a nice distribution, but most impressively is the fact that the BMIs here are much heavier than they are in adults. A number of these kids, if you will, have BMIs of 50 to 59, and some actually have BMIs greater than 60. So to get into an adolescent bariatric surgery program, generally kids are much, much heavier than adults who have bariatric surgery. That has certain implications. It means, for one thing, that when they lose weight, they generally do not get back to a normal weight. They generally are still overweight or obese. And because of that, we need to find out about remission with medical comorbidities. Next slide, please. So what do we find in this data set? We've only analyzed the data out to 2 years. Meg Zeller published this a couple of years ago. And as you can see, baseline surgery, baseline non-surgical. Look at the audit alcohol use disorder, which is the third line. As you can see, the baseline surgical and non-surgical are very similar. The 24-month surgical and non-surgical are very similar. So we don't have evidence that by 2 years, more of these adolescents are starting to use alcohol in a problematic way. We need to follow them further out, and that'll tell the tale whether or not this is a problem or not. Just have not analyzed data out beyond 2 years yet. Next slide. And this is looking at the subtypes of bariatrics. As you can see, compared to the non-surgical controls, Roux-en-Y and sleeve are robust and not that different. There were only 10 bands in this sample, and none of those patients appeared to get into trouble, which would fit with what we know from data in adults, although the sample size there is obviously quite small. Next slide. The other issue that's emerging increasingly is opioid use. These are data that were first reported by Ravel in JAMA in 2013. And this is looking at mean daily morphine equivalent doses. So if people were on morphine, that was counted as a morphine equivalent. If they were on other opiates, they were converted to morphine equivalents, because not everybody gets morphine. And as you can see, after bariatric surgery, the chronic use of opiate morphine equivalents actually goes up. Now, we would anticipate that, if anything, it would go down because people have less arthritic symptoms. They should be better off in terms of a number of problems that may require opiates. But on the contrary, what we find is the chronic use of morphine equivalents actually goes up in this data set. Next slide, please. And these are the opioid data from Labs 2. Again, a little over 2,000 people, mostly women. Limitation in this data set, always retrospective, you always want to change something. But the major limitation with this data set is we don't have dosage data. All we have are the number of people taking opiates. In retrospect, that was an oversight and a problem. Next slide. However, if we just look at the number of people on opiates, that's the gray line, kind of the third line down. What you notice is that the use of opiate analgesics goes up. Next slide, please. And this is looking at continued use, which is the blue line, versus overall use, which is the black line, versus initiated post-surgery. And what this shows is that the number of people who are initiated post-surgery goes up over time. And it seems to plateau at about 4 years. Next slide. So are there variables that are associated with onset of opioid use post-surgery? Public versus private insurance, more pre-surgery pain, undergoing another post-bariatric surgery procedure, less improvement with pain, and using starting or continuing non-opiate analgesics. All of those appear to correlate with onset of opioid use surgery. Next slide, please. Also, a study just came out from Sweden, and they looked at what they classified as high opioid consumers who were taking more than 10 milligram morphine equivalents a day versus low opioid consumers, which was less than 10 milligrams a day. Next slide. And again, they found the same thing. They found that the number of patients who were taking high-dose opioids actually went up, as opposed to what we assume would happen. Next slide, please. So what's going on? We don't know exactly, but one of the problems with opiates appears to be that they are hyperabsorbed, at least the ones we've studied so far, after bariatric surgery. These are data from Brett Linares, who did this work when she was in Paris. She's actually in Geneva now. And as you see, the baseline pre-surgery is the black line, 15 days post-operatively, more absorption, greater area under the curve, and 6 months post-operatively, again, hyperabsorption of opiates. So people are using more opiates, but they also seem to be generating higher serum levels. And this is a great concern, and one of the reasons why we're very worried now about using opiates in bariatric patients. Next slide, please. Now, we also have data with methadone. These are data, the blue line is preoperatively, the red line 5 days, green line 1 month, orange line 7 months. And as you can see, it seems like hyperabsorption actually increases over time. Now, there are lots of different opiates, and they're metabolized in various ways, and many of them have not been studied. So we don't know if this is true of all opiates or just some opiates. But nonetheless, it's a signal that something is highly problematic. Next slide, please. I just wanted to throw this out very briefly. There's also been speculation that other impulse control problems may increase after bariatric surgery. And as far as I know, these are the only data that have been published, and they're not definitive. We administered impulse control modules and skids to about 200 patients. Next slide, please. This is what we found at 3 years. Any other addictive disorder went up a little bit. There were 6 new cases. 3 of them were impulsive compulsive buying. 4 of them were impulsive compulsive internet use. Is this impressive? Not particularly. The sample size is really too small. We need better data, a much larger sample size. So I think we have to conclude that these data don't suggest a huge problem, but really are not definitive. Next slide, please. So what are the implications for this? Well, there's a lot of concern now about using opiates, and there are a number of regimes that have been published in the literature to try to use non-opiate medications as a way of treating bariatric surgery patients. Acetaminophen is one of them. Tomidine, is another one. There's a new surgical procedure called tap blocking, where you actually numb nerves that are involved in signaling pain in the abdominal field where there's been an incision. Ketamine is being used. Tramadol appears to be maybe the safest opiate, but we don't know that for sure. So surgery groups who are working with these patients really need to take a good hard look at trying to develop other ways to treat pain in bariatric surgery patients. Next slide. So in summary, the prevalence of, after Roux-en-Y, alcohol problems is about 14%. Cumulative incidence about almost 21%. We need more data on sleeve, but right now the sleeve data are worrisome. Illicit drug use, 7.5%. New onset Roux-en-Y gastric bypass. Opiate use at 7 years, 14%. Again, we need opiate use data on sleeve gastrectomy. We need to look at additional opioids to find out if the kinetics are altered. We really have inadequate data yet to talk about addictive behaviors. And the teen labs data don't suggest a huge increase, but this is still potentially problematic. As you know, if we look at changes in the kinetics and the reinforcing properties, a lot of these patients now are entering adulthood. And they go into the workforce, they leave home, they go to college, and a lot of them do not tell their friends that they have had bariatric surgery. And so if they're drinking at the same level as their peer group, they may be getting into problems. That's a prediction we need to follow up on as we look at the longer term teen labs data. Next slide, please. So I think the implications are we need to try to interview other family members during pre-surgery evaluation. We need to acknowledge that patients are not always forthcoming about their alcohol use or about other kinds of problems. And if we can get additional information from other people in their environment, that's very useful. We need to do careful informed consent regarding alcohol and opiates, and probably other substances of abuse as well. We need to follow up routinely to find out about these things. And a lot of times the follow-up of our bariatric patients is not very thorough. A lot of times it involves a phone call to find out about their weight, and probably need to institute better policies in terms of following these people up. We also need to avoid use of opiates if we can, and these alternative strategies, if at all possible. So I think that's my last slide. So I'll stop there and we'll do Q&A. Thanks very much for listening.
Thank you so much for the presentation. I believe Colleen is going to try and moderate some of the questions for the question and answer portion of the webinar.
Great.
Colleen, it seems like you might be on mute. I can read the first question because I saw one just come in from Kelly Allison, which was, do you know how long patients remain intoxicated? Is it longer or shorter than for those who have not had surgery?
Oh, hi, Kelly. How are you? I think the data would suggest that it actually is a bit longer. It's not consistent. Uh, One of the things we noticed in the one study that I mentioned that Christine Stephan published was that this is anecdotal, but it seemed like when people had such a high peak that many times their ability to judge the severity of their impairment was compromised. And so we had people who were still legally intoxicated in that study who were saying, I'm okay now, I can go home now, when they still had an elevated blood alcohol level. So this is speculation, but again, I think there's a suggestion anyway that when you get this huge early peak, that it may have disrupting effect on people's ability to judge their own level of intoxication.
Can you hear me now?
Yes.
Yes.
Wonderful. So the next question comes from Robin Cisco, and it says, what do you think about advocating to insurance companies to cover or require a post-operative evaluation to capture patients with alcohol and drug problems?
Well, I think that's a wonderful idea. I think such a move would be fruitful a number of places in the world other than the United States. Robin, as you know very well, the reimbursement for bariatric surgery is a bundled cost. And so every dollar not spent is profit for hospitals. And so getting them to add on either pre-surgery or post-surgery visits is very, very difficult. So until, and I say that very optimistically, we have a better health insurance system than we do now, I think that's unlikely to transpire in the United States. Other places, I think it could very easily be instituted. And some places are notoriously good for doing follow-ups. Germany, for example, and Australia and New Zealand have much higher hit rates than we do in the United States.
Thank you. A follow-up question that I myself have is, in looking at these studies in which patients are consuming alcohol in laboratory studies, I'm wondering about the method that's being used in terms of whether or not it's generalizable to what patients might be doing in social situations, for example.
Yeah, very, very good point. I don't think it is. You know, the environment is very different, and to assume that we can just logically translate that to the social situations, I think is we just can't do that. I think the drug administration studies are extremely useful, but there are limitations in terms of generalizing them to the real population. The cues are very, very different. It's a very good point.
And so in terms of advising our patients about risks, what would be your suggestions? Like if you were going to do a careful, informed consent, how might you go about doing it with a patient?
Well, I think there are guidelines ASMBS has published about how to do it, and there actually been some consent forms floating around where programs are trying to come up with the best way to do it. I think the key ingredient, though, is we have to do the follow-ups, and we have to do a very careful job with the follow-ups. I think we probably all had patients just very quickly get into problems with alcohol, some of whom have never used alcohol before, a few of whom have never drank before. It's amazing how quickly this can develop. So I think we need routine follow-up directly addressing the issue of alcohol.
Thank you. That's helpful. Our next question is asking, is there any data on the impact of alcohol consumption on weight loss outcomes or weight outcomes?
Weight loss outcomes, not a lot. What's been published so far is somewhat ambiguous, but it doesn't appear to be a major player, so far anyway. There are, in the lab study, for example, we've looked at alcohol use as a predictor of 7-year weight loss and really have not seen a strong effect. One of the problems in this whole area is that when you look at variables, either preoperatively or postoperative variables, there's so much noise. There's so many things going on. It's really hard to predict. I think one of the biggest disappointments in the lab study was that we couldn't identify any pre-surgery predictors, that accounted for much of the variance. And that was really disappointing because we'd like to say to a person, given your history, given what's going on here, this is what you can anticipate. And the data just are not there. So it does appear that the main behavioral variable that we have that seems to account for weight loss differences is the problem with loss of control or binge eating. And that's been replicated now in a number of studies. And that's not necessarily correlated with alcohol use. So that is the one behavioral variable we found that clearly appears to be important.
Okay. The next question is about opioid prescribing after surgery. And it says, at Mount Sinai, the surgeons have moved away from using opioids during and immediately after surgery and only using them when absolutely needed. Do you think those kinds of shifts might influence post-operative drug abuse risk? Or is it less about exposure around surgery and more about change in reward reinforcement of these medications?
That's a good question too. I think it's a very good move. I think that's the way the field is going now. Try to avoid them if at all possible. Whether that really impacts on the risk, we'll have to see. Unfortunately, people who are looking for opiates, well, this is getting better, I think, but there are various ways of getting a hold of opiates, and if the surgeons are trying to find alternatives, that's great, but that doesn't keep somebody from going into the emergency room and seeking something. I think given the opiate crisis in the United States now, this is getting better. I hope it's getting better, but still there are a number of doctors out there who are more than happy to prescribe opiates.
Yes, thank you. The next question actually is one of mine that I have, and I was curious that patients who were reporting baseline alcohol abuse, especially in teens, were that was not considered a contraindication to surgery. I was surprised that they were having surgery in spite of reporting alcohol abuse or dependence at baseline. Is that typical for that age group? For that not?
No, I'm sorry. No, it's not. One of the things in labs and in teen labs is that routinely we ask people about alcohol abuse before surgery when we follow them up. And I think they're much more likely to be honest with us at that point. So those data are based on retrospective reporting. And I think that's really the only way we can find out. If people know that they report this and they're not going to get surgery, they're not going to report it. So I think we need to routinely ask people about this after surgery.
Then more to your point about the importance of the follow-up.
Yes. exactly. And one of the, the teen labs data are very, very interesting. Um, it's this is a really open question. Uh, when should we refer adolescents for bariatric surgery? There are still people out there who think it's always a mistake. We should wait until people are older. However, the data are starting to suggest that we will have a better outcome and we will more likely experience resolution of medical comorbidities if we don't wait. And for example, the remission rate from diabetes is higher in teen labs than it is in adult labs. So I think a strong argument can be made now that we need to, obviously we need to study this in greater detail, but given the severity of obesity in our population and the number of kids, 15-year-old kids that weigh 400 pounds and have diabetes and have hypertension and basically have no life, you really need to strongly consider bariatric surgery.
Thank you. Another related question to alcohol is that an insurance provider in their area is requiring that a patient stop drinking completely before surgery, or they will not be pre-certified. And the author of this question was saying, it seems that we do not have the data to support this approach, and was wondering whether or not you agreed with this approach or not.
Well, I don't know if it's going to make any difference. As you know, it's really difficult to tell when somebody is drinking excessively, particularly in people with severe obesity. You're going to have abnormal liver function tests anyway. So we don't have a litmus test where the patient can come in and we can say, you've been drinking. There are tests now that are in development that have some utility in that regard, but they're not foolproof. So if insurance companies start requiring that, then I think patients will start telling physicians that they're not drinking. And I'm not sure that's going to be true. We also, I think, need to bear in mind that a number of the people that develop alcohol problems have never had a problem before. And so it's not a guarantee.
So I think what I hear you saying is we really need to balance the fact that patients may not be honest if it's a requirement against the need for them to go and have bariatric surgery to have the positive effects associated with it.
Yeah, right. And I think that's true. You said it better than I did. Well, we just know from various studies that people are just not particularly forthcoming when they come in for an evaluation. Unfortunately, that's true. And we know that the concordance between the data that are obtained in routine psychological evals and the data that are obtained in research settings where the data are not going to be shared with the surgical team are quite different.
It also makes me wonder, and I know that this is mentioned in several of the papers that you've published on the data, that there actually might also be a shift in environment or in social kind of availability of patients when they're feeling better, when they're getting out more after surgery, and with resolution of comorbidities and other kinds of things. So they may just be around alcohol more because social situations often involve alcohol. So even as much as we do pre-surgery, there may be just a different kind of context that develops once people have had surgery.
Yeah, very good point. Very good point. Yeah, things change rather dramatically from people. We know from that recent report from Sweden about the fact that people are much more likely to go through relationship changes after bariatric surgery. That may be getting married or it may be getting divorced. So I think that's an index of the fact that their lives are changing dramatically, more likely to find themselves in social situations where they're going to be exposed to alcohol. And I think that's particularly concerning with the adolescents. at this point.
Thank you very much. So we are now at the 5-minute warning. So we have time for just a few more questions before we will promptly end the webinar at 12:55. And one question I have coming in is that from the data that you showed, there's an increase in opioid use. Is there also an increase in reported pain post-surgery at 6 or 12 months down the road?
It would appear that people who are experiencing more pain are at increased risk for ending up on opiates, opioids. That's true. So that seems to be one of the risk factors, yes.
Do you think that there's a difference when it comes to adolescent patients about preparation for college and the kinds of other environmental situations that they might encounter when, you know, they are experiencing both significant developmental shifts and significant changes in physical health and weight?
That again is a very good point. And actually the DSMB, the Data Safety and Monitoring Board for Teen Labs, has had a great deal of concern about informed consent and education about these sorts of problems. Actually, more scrutiny in that study than there was in the lab study. And so they're following that very closely, and as in any kind of severe obesity situation, you're going to have some morbidity and mortality. So the importance of teen labs is we really need, there are all kinds of questions we don't know the answer to. And fortunately, I think Tom Inge, who designed the teen lab study, did a good job in terms of trying to include a very, very broad array of assessments, not just medical, but also psychosocial.
I'm curious, I know one of your recommendations today was to try to interview other family members during the pre-surgical evaluation. One thing that I think can arise from that is that you may receive very different reports about patient behaviors from family members than from the patient themselves. How would you advise for clinicians to, I guess, manage that when, for example, a family member is saying, no, the patient is drinking quite regularly, whereas the patient is denying this?
Yeah, it's obviously very tricky, and you obviously need informed consent to get those data. But it seems to me to be enough of an issue, and we know from the concordance data that a lot of the self-report is going to be flawed, that we should require that of our patients. And then how you deal with it is ranges from confrontation to insisting people get further evaluation.
Okay, wonderful. Well, I think we have read the remainder of the questions, and I want to thank you so much, Dr. Mitchell, for being here with us today and providing us with this information.
Well, my pleasure. Thank you for tuning in.
Okay.
And we just want to remind everyone that a link to the recording of the webinar will be sent to the SIG community by dawn in the next several days. So if you have other people who would be interested in hearing the information, that will be available to them and distributed by the community website. And thank you to everyone who was here today and participated, the questions, and for listening, and enjoy the rest of your afternoon.